very good morning to Prof. Jose, Prof. Ranjit, and my fellow classmates. Today, my group members, Danisha, Kashwini, Darnia, and I will be presenting a seminar on the topic chairside investigations. So, I'll start with our learning outcome first. Explain the chairside investigation used in diagnosing various oral diseases or lesions. Chairside investigations are simple, require inexpensive equipment, and rapidly doing procedures. It is carried out conveniently in a clinic or dental office setup. Chairside investigations serve as an important tool in assisting the dentist to confirm the diagnosis and check out the various treatment plans according to the patient's needs. So we can classify chairside investigations into 7 main classifications. The first one will be the investigation for hard tissue examination, which includes the pulse vitality test, pulse oximetry test cavity, selective anesthesia, laser Doppler flowmetry, photoplethysmography, spectrophotometry, surface temperature measurement, caries detection test, plaque dispersing agents, mobility test, and test to detect cracked tooth. The second one will be the test for detection of vascular lesions, which includes the diascopy. And the third one is the test for detection of potentially malignant lesions and conditions, which includes the vital staining, light-based detection system, cytological technique, and histological technique. The next one will be the investigation for maxillary sinus, which includes the transillumination test. And then we have investigation for saliva and taste evaluation, which includes the collection of whole saliva test for xerostomia, test for detection of taste disorders, and test for oral malodor. The sixth one is the investigations for allergy, which includes the skin prick test and the patch test. And the last one will be the investigations for neuromuscular disorder, which includes the diagnostic nerve blocking test. First, I'll be starting with the pulse vitality test. Pulse testing is often referred to as vitality testing. Pulse vitality tests play an important role in diagnosis because the tests not only determine the vitality of tooth but also the pathological status of pulp. Pulp tests should only be used to assess the vital or non-vital pulp as they do not quantify the disease nor do they measure the health and thus should not be used to assess the degree of pulpal disease. There are several uses of pulp vitality tests, which includes to confirm whether radiolucent area present at apical part of the tooth because of pulpal origin, other pathological reasons, or it is a normal anatomic structures. Pulse vitality testing is also used to diagnose oral pain whether it is of pulpal or periodontal origin or because of other reasons. So I will start with the cold test first. Cold test is the most commonly used test for assessing the vitality of pulp. It can be done in number of ways. The most commonly used method for performing pulp testing is spray with cold air. The cold air is directed against the isolated tooth. The other method used in cold test is wrap an ice piece in the wet gauze and apply it to the tooth. The ice piece can be prepared by filling the discarded anesthetic capsules with water and placing them in refrigerator. Usually, we will start with the adjacent tooth first by placing the ice stick or spraying with the cold air on the cervical area of the tooth because enamel is thinnest on that area and the conductivity to pulp is faster. There are 3 conditions exist in cold test. So the first one, if patient feels immediate pain that lasts for 1 to 3 seconds after removal of the ice sticks, it indicates a vital pulp. If patient feels immediate severe pain that lasts for several minutes after removal of the ice stick, it indicates a irreversibly inflamed pulp. And if patient feels nothing, it indicates a non-vital pulp. The second test I'm going to talk about is heat test. Heat test is most advantageous in the condition where patient's chief complaint is intense dental pain upon contact with any hot object or liquid. There are different methods used for heat test. The most common method is by using a heated gutta percha. Heated gutta percha stick is the most commonly used method for heat testing. In the method, in this method, tooth is coated with a lubricant such as petroleum jelly to prevent the gutta percha from adhering to tooth surface. The heated gutta percha is applied at the junction of the cervical and middle third of facial surface of tooth, and patient's response is noted. While using a gutta percha stick, precautions should be taken not to overheat it because in this state it is at higher temperature than required for pulp testing and it may result in pulp injury. The preferred temperature for heat test is 150 Fahrenheit or 65.5 degrees Celsius. There are three conditions exist in heat test. If patient feels immediate pain that lasts for 1 to 3 seconds after removal of the heated instrument, it indicates a vital pulse. If patient feels immediate severe pain that lasts for several minutes, it indicates a irreversibly inflamed pulse. And if patient feels nothing, it indicates a non-vital pulse. There are few disadvantages of using this heat test. The first one is it is difficult to use on posterior teeth because of limited access. And the second one is excessive heating may result in pulpal damage. The next test is the electric pulp testing. Electric pulp tester is used for evaluation of condition of the pulp by electrical excitations of neural elements within the pulp. The pulp tester is an instrument which uses the gradation of electrical current to excite a response from the pulpal tissue. Pulp testers are available with cord which plug into electric outlets for power source. They can also be available as battery operated instruments. As you can see in the picture below, this is how an electrical pulp tester looks like. If gloves are not used, the circuit gets completed when clinician's finger contact with electrode and patient's cheeks, but with gloved hands, it can be done by placing patient's finger on metal electrode handle or by clipping a ground attachment on the patient's lip. Once the circuit is complete, slowly increase the current and ask the patient to point out when the sensation occurs. Each tooth should be tested 2 to 3 times and the average reading is noted. If the vitality of the tooth is in question, the pulp tester should be used on the adjacent teeth and the contralateral tooth as control. There are several disadvantages of electrical pulp testing. Following conditions can give rise to wrong results. First one is the false positive response. False positive responses are seen in teeth with acute alveolar abscess or when the electrode contact with the gingival tissue, or it is seen in the multi-rooted teeth where pulp may be vital in one or more root canals and necrosed in others. The second one is the false negative response. False negative responses are seen in recently traumatized tooth, recently erupted tooth with immature apex, calcified canals, and patients with high pain threshold. Moving on to the test cavity. This method should be used only when all the other test methods are inconclusive in results. Here, a test cavity is made with high-speed number 1 or 2 round bursts with appropriate air and water coolant. The patient is not anesthetized while performing this test. Patient is asked to respond if any painful sensation occurs during drilling. The sensitivity or the pain felt by the patient indicates a pulp vitality. Here the procedure is terminated by restoring the pipette cavity. If no pain is felt, cavity preparation may be continued until the pulse chamber is reached, and later on, endodontic therapy may be carried out. The next one is the anesthetic test. When patient is not able to specify the site of pain and when other pulse testing techniques are inconclusive, the selective anesthesia may be used. The main objective of this test is to anesthetize a single tooth at a time until the pain is eliminated. It should be accomplished by using intraligamentary injection. Injection is administered to the most posterior tooth in the suspected quadrant. If the pain persists even after tooth has been fully anesthetized, then repeat the procedure to the next tooth mesial to it. It is continued until the pain disappears. If source of pain cannot be determined, repeat the same technique on the opposite arch. Moving on to the caries detection test. Examples of caries detection test is fiber optic transillumination test, or also known as FOTI. As we all know, caries lesions have a lower index of light transmission. So, when these tooths are examined with a fiber optic light source, caries appears as a darkened shadow. After drying the tooth, a fiber optic probe can be placed in the buccal or lingual embrasure directly beneath the contact area between the two adjacent tooth. If caries is present, it is evident as a dark shadow beneath the marginal ridge. This is a picture showing a fiber optic transillumination test. The next one is disclosing agents. A disclosing agent is a preparation which comes in liquid, tablet, or lozenges form, and they contain a special dye or other coloring agents. The most common dyes are bismuth brown, fluorescein, and basic fuchsin. When these disclosing agents are applied to the teeth, the agent imparts its color to soft deposits, but can be rinsed easily from the clean tooth surface. Coming to the mobility test. Mobility can result from trauma, root fractures, periodontal diseases, and gross root resorptions. A suspected tooth can be moved gently by finger and thumb pressure or with two rigid instruments such as mirror handles. Any horizontal mobility is then graded as Grade 1, Grade 2, and Grade 3 mobility. If it is a Grade 1 mobility, it indicates a distinguishable sign of tooth movement which is more than normal. If it is a Grade 2 mobility, it means there is horizontal tooth movement not more than 1 millimeter. And if it is Grade 3 mobility, it means movement of tooth more than 1 millimeter or when tooth can be depressed. Moving on to the test to detect cracked tooth. Tests to detect cracked tooth can be done using a visual examination, tactile examination, bite test, crack detection with dyes, periodontal probing, and caries finder. So first, I will be talking about visual inspection. Visual inspection of tooth is useful, but cracks are not often visible without the aid of magnifying loops. Second one is the tactile examination. Tactile examination can be done by just scratching the tooth surface with the tip of sharp explorer. The tip may catch in a crack. The third one is the periodontal probing. This method helps to distinguish between a cracked tooth and a split tooth when the fracture line extends below the gingiva, thereby causing a localized periodontal effect. Isolated deep probing often indicates the presence of split tooth. Moving on to the bite test. These tests help in identifying a cracked or fractured tooth. This is done if patient complains of pain on mastication. Tooth is sensitive to biting if pulpal necrosis is extended to the PDL or if a crack is present in a tooth. In this patient is asked to bite on a hard object such as cotton swab, toothpick or orange wood stick with suspected tooth and the contralateral tooth. Tooth Sleuth is another commercially available device for bite tests. It has a small concave area on its top which is placed in contact with the cusp to be tested. Patient is asked to bite on it. Pain on biting may indicate a fractured tooth. A pain present on biting may even indicate a pical periodontitis. If there is pain on releasing the biting force, it indicates a cracked tooth. The last one I'm going to talk about is crack detection with dyes. The most common dye which is used in crack detection test is methylene blue stain. They can be used to highlight the fracture lines. The main disadvantage of this technique is that it takes at least 2 to 5 days to be effective and may require placement of provisional restoration. Placement of provisional restoration may further propagate the crack. That's all from me.
Thank you, Rohini. My name is Danusha. Now I'll be continuing the seminar. Test for detection of vascular lesion, diascopy. What is diascopy? Diascopy is a clinical blanchability test by applying pressure with finger or glass light and observing color changes. Hemorrhagic lesions and non-vascular lesions do not blanch, whereby inflammatory lesions do blanch. It is the simplest method for assessing superficial erythema. The purpose of diascopy is to empty blood from superficial vessel to determine if skin redness is due to blood within vessels, which is erythema, or extravasated into skin, which is petechiae and purpura. Clinical significance. Specific indication for the use of diascopy include telangiectasia, petechiae and purpura, superficially dilated veins, granulomatous nodules such as sarcoidosis, granuloma annuli. The test for detection of potentially malignant lesions and conditions. There are vital staining, under vital staining, toluidine blue staining, Lugol's iodine, methylene blue, rose bengal. Under light-based detection system, tissue fluorescent imaging, chemiluminescence. Under cytological techniques, oral brush biopsy and fine needle aspiration, cytology. Moving on to vital staining. Toluidine blue. Toluidine blue is a metachromatic dye which stains tissue rich in nucleic acid. Dysplastic and neoplastic cells contain more nucleic acid than the normal cells. Malignant epithelium contain wider intracellular canals, facilitating penetration of the dye. Toluidine blue stained tissue appear dark or royal blue, used as aid for screening and post-surgical management of oral pre-malignant disorders and oral cancers. Toluidine blue staining can yield a high percentage of false positive results. Some benign hyperplasia and inflammatory lesions can be stained. Traumatic benign lesion can also be stained, but they differ from malignant lesions. To reduce false positive rate, further assessment of a non-healing wound after at least 15 days is highly recommended. Lugol's iodine. When it is applied on suspicious lesion, normal mucosa stains brown and megaphony due to its high glycogen content, while dysplastic and cancerous lesions do not stain and appear pale compared to the surrounding tissue. It is effective as a screening tool for oral PMD and oral cancer. Staining during surgery can determine surgical resection margin. This is a Lugol iodine staining in buccal mucosa. Moving on to methylene blue. Methylene blue was first used in detecting oral mucosa lesions in 2007. Similarly to TB, which is toluidine blue, methylene blue stains tissue with large quantities of nucleic acid. They are useful for screening oral cancer in high-risk individuals and show high sensitivity in detecting oral PMDs. Moving on to rose Bengal. Rose Bengal staining is widely used to diagnose ocular surface disorders. It stains desquamated ocular epithelial cells, dead or degenerated cells, but it does not stain healthy epithelial cells. The efficacy of RB staining, rose Bengal staining in detection of oral PMD and oral cancer and epithelial dysplasia in oral leukoplakia, lichen planus, leukokeratosis, combine fluorescent spectroscopic techniques with rose Bengal staining. This shows negative staining with rose Bengal, which shows mild dysplasia, whereby positive intense staining with rose Bengal shows moderate dysplasia. Moving on to light-based detection system, tissue fluorescent imaging or well scope. This detects early dysplastic changes. Autofluorescent property of oral mucosa, blue light excitation 400 nanometers. Normal oral mucosa emit a pale green autofluorescent when viewed, whereby abnormal mucosa exhibit decreased level of autofluorescent, appearing dark when compared with surrounding tissue. Loss of autofluorescence is not limited to epithelial abnormalities, can be seen with prominent surface vascularity. Areas of inflammation, melanin pigmentations. Atypical or suspicious tissue exhibit decreased level of normal autofluorescence and appear dark by comparison to the surrounding healthy tissue. Moving on to chemiluminescence, visilight. Chemical reaction between hydrogen peroxide and acetyl salicylic acid inside the capsule light stick. This is the capsule light stick. The procedure is rinsing the mouth with 1% acetic acid solution for 1 minute. Identification of abnormal oral mucosa. This aids in early detection of cancer is to have both low false negative rate and low false positive rate. Moving on to cytological technique, which is oral brush biopsy. This biopsy method utilizes an improved brush to obtain a complete transepithelial biopsy specimen with cellular representation from each of 3 layers of the lesion: the basal layer, intermediate, and superficial layers. The oral brush biopsy instrument has 2 cutting surfaces, the flat end of the brush and circular border of the brush. Either surface can be used to obtain the specimen. So this shows, picture A shows a specimen collected and smeared on glass slide and undergoes staining. Now moving on to fine needle aspiration cytology biopsy. When a lump or a bump is discovered in a superficial areas of the body, such as breast, neck, fine needle aspiration cytology is recommended to determine whether the lump is cancerous. This test also used to test thyroid, salivary glands, and lymph node illness. The procedure is insertion of a small needle along with syringe attached, and suction is applied, allowing more material to be obtained. Needle inserted and drawn in and out for about 5 seconds and then withdrawn. The material then smeared on a glass side and undergoes staining.
Hello, so I will continue with investigations for maxillary sinuses And here we use the transillumination test. Okay, so this test is used to diagnose sinusitis when the sinus is infected or blocked. The procedure is simple. It is performed in a dark room, and then using a flashlight or a transilluminator, you place it onto the roof of the mouth, then you flash it. If the sinuses are normal, there will be a red glow as seen in the picture below. But if the sinuses are blocked or infected, there will be a transillumination. So there is a link below that shows how the procedure is done. You may click it out, you may click on it and check it out. Okay, so moving on to investigations for saliva and taste evaluation. How do you collect saliva? Okay, so there are a few methods. The first one is draining technique. So here the patient is made to sit upright with the head tilted forward, and the saliva is allowed to drip passively into a sterile tube. So since there is no stimulation involved, this technique is considered to be more reliable. The next technique is called spitting technique. So here, the saliva is allowed to accumulate into the floor of the mouth and then spit it out into a sterile tube or container. The disadvantage of this method is that there is stimulatory effect involved. So because of this, this method is not used for unstimulated saliva collection. The third method is called suction method. So here the saliva is allowed to accumulate into the floor of the mouth and then later aspirated out using a pipette, a micropipette or a syringe. So there is a video that shows how to collect saliva. If you're interested, you can check it out. Now, if you want to collect saliva from more specific glands, there's a few devices. The first one is called Carlson Crittenden device. This device, we use it to collect saliva from specifically the parotid gland. An average of 1 to 1.5 milliliter of saliva can be collected within the first 10 to 15 minutes. But the disadvantage of a Carlson Crittenden device is that it is complex, slow, and invasive. Now, if you are interested to collect saliva from the submandibular gland and the sublingual gland, we use a segregator. So a segregator has two chambers. The central chamber will collect saliva from the submandibular gland, and the two lateral chambers will collect saliva from the sublingual gland. But this procedure is time consuming. Okay, now we use a periotron to collect saliva from the minor salivary glands. So a periotron will actually display uh, volume of in units and it shows the quantity of saliva. So by using a filter paper known as perio paper or cialo paper absorbent method, so from absorbing the saliva and then using a periotron, it will display the number. So moving on. Um, okay, so how do you test for xerostomia? There is two methods for that. One is the lipstick sign and one more is the tongue blade sign. So the lipstick sign, uh, in a normal patient, if there is any lipstick smear on your labial surface or buccal mucosa, usually the saliva will help in cleansing the part of that surface. But in a patient who's got lesser saliva secretion, the stains will not be removed. So basically that is lipstick sign. There will be stains on your oral surfaces, either the labial surface or the mucosal surface. Then for tongue blade sign, using a tongue blade, if you place it against the buccal mucosa, you will realize that it will be harder to remove the tongue blade from the mouth because it will adhere to the tissues of your buccal mucosa. This is seen in a dry mouth. So that is tongue blade sign. Meaning if you find it hard to remove the tongue blade from the mouth, that is called a tongue blade sign. Okay. Now, to test for taste disorders, we use electrogastrometry to examine the taste sensitivity. So we will use electric current uh, to create a response to the irritation of the taste buds. And this technique is especially useful in estimating the efficiency of sensory pathways. So the stimuli used, we use citric acid or hydrochloric acid for sour taste, caffeine for bitter taste, sodium chloride for salty taste, any type of sweetener for sweet taste, and monosodium glutamate for umami taste. Next, whole mouth sip and speak method. So in this, the subject is able to detect, identify, and evaluate the intensity of the concentration of all the stimuli, sweet, sour, salty, bitter. So the method is that the predetermined concentration of the stimuli is given to the subject and then to be gargled and then spit out. And then the subject will identify the taste and the concentration. So is it like very sweet? Is it mildly sweet? Is it salty? You know, and so on. But the disadvantage of this test is that there might be original damage that would mask the stimulation of the remaining taste in the oral cavity. So meaning that if a bitter stimuli were to be given prior to a sweet taste, the subject might get confused between if it's still bitter or not, because that taste will still linger into the on your mouth. So yes, that's all from my part. Now I will pass the floor to Kashwin to continue.
Thank you, Dania. So today I'm going to talk about tests for oral malodor. There are 6 tests for oral malodor. So the first test is organoleptic method. It's also known as sniffing test. So organoleptic method is a sensory test used to score on a basis of the examiner's perceptions on the subject's oral malodor. And it is also carried out simply by sniffing the patient's breath and by the scoring level of the oral malodor. Now I'm going to explain how they do that. So by inserting the translucent tube, this is the translucent tube, into the patient's mouth and having the person exhale slowly. The breath is undiluted by the room air, so it can be evaluated by the organoleptic score. And then there's a tube the tube is inserted through the privacy screen. This tube is inserted through this privacy screen that separates the examiner and the patient. So this privacy screen allows the patient to believe that they have undergone a specific malodor examination rather than the direct sniffing procedure as shown on the right on the picture on your right side. This is the wrong way of doing it. This is the right way of doing it. So now I'm going to talk about organoleptic score, which is 0 to 5 by Rosenberg in 1991. This guy introduced this score method. So score 0, it means absence of halitosis. That means odor cannot be detected. Score 1 means questionable halitosis. That means odor is detected although the examiner could not recognize as a halitosis. Score number 2 is slight halitosis. Score number 3 is moderate halitosis. Halitosis is definitely detected. Score number 4 is strong halitosis. Strong halitosis is detected but can be tolerated by the examiner. Score number 5 is severe halitosis. Means overwhelmed halitosis is detected and cannot be tolerated by the examiner. So the second test is volatile sulfide monitor. Okay, this electronic is called helimeter. This is the helimeter. It's a portable sulfide meter which used to analyze the concentration of the hydrogen sulfide and methyl mercaptan, but without discriminating between them. The sulfide meter uses a voltmeter sensor that generates a signal when exposed to sulfur containing gases. So as you can see in the picture, this is the helimeter and this is how they use this helimeter. Alright, okay, so this machine measures the level of sulfide gases around the person's breath. but it has certain drawbacks in clinical application. Some of the common sulfides, such as mercaptan, are not easily recorded and can be misinterpreted in the test results. So the helimeter is also a very sensitive to the alcohol. So avoid drinking the alcohol before you come to the test. So you should not take the alcohol containing mouthwash, or at least like 12 hours prior before the test. So you cannot drink alcohol, you cannot uh, use the mouth rings goggles also. So the third test I'm going to talk about gas chromatography. Gas chromatography is a specific detecting sulfur in the mouth air. Its most important advantage of the technique is that it can detect virtually any compound when using adequate material and conditions. It has a very high sensitivity and specificity. It is also potable gas chromatography. There are three gases, which is hydrogen sulfide, methyl mercaptan, dimethyl sulfide. Example, if there's like more methyl mercaptan than hydrogen sulfide, that means they have periodontitis. If there's hydrogen sulfide increases, that means they have poor oral hygiene. And if there's only dimethyl sulfide, that means extra oral causes. So gas chromatography is considered the gold standard of measuring oral malodor. This device can analyze air, saliva, cervical fluid for a voltic component. So as you can see in this page, there's GC, MS and TD. Okay, GC is gas chromatography. Gas chromatography does not work alone. It includes TD and MS. TD stands for thermal desorber. This is TD. It is used to release molecule trapped in the special collector. Okay, so GC is gas chromatography. Gas chromatography is used to separate the molecules. And MS is means mass spectrometer. It is used for identification of the molecule. As you can see on the picture on the right side, on the left side, you can see the portable gases. This portable gas chromatography. This is portable gas chromatography. This is the portable one. So the small amount of the blood sample aspired with a plastic syringe is injected into the input port of the GC. The computer displays the detection and amount of three important VSC within 8 minutes. VSC means voltic sulfur component, and this is the computer where you can see the readings. So now I'm going to talk about helitoxis system. So helitoxis system is a quick and simple. It detects the VSC. As I said, it's known as voltic sulfur component and polymines in the sample. The absorbent point given with the kit is inserted into the pocket. This is the absorbent point. So it is left in the place for 1 minute. Submerge the absorbent point tip in the toxin reagent. Okay. So and then you have to wait for 5 minutes and see for yellow color in the specimen. You have to see the yellow color in this specimen given here. Okay, so you have to see the yellow color in the specimen on the scale of 0 to 3, which is directly proportional to the level of the toxin in the sample. So the fifth test is electronic nose. So the electric nose was developed in order to mimic the human olfaction. It consists of formation of sensory which are able to generate the electrical signals to respond to either a simple or complex or voltic component present in the gases sample. Okay, E-nose consists of three major parts, which is sample delivery system, detection system, and computing system. So as you can see in this picture, this doctor used the electronic nose like to clinically assess the oral malodor and examination that associated between oral malodor strength and oral health status of this patient. As you can see, this is the electronic nose. This is the electric nose. This is the machine to detect the readings. The sixth test that I'm going to present is Banner test. Banner test, or it's practically for chairside usage, and it is used to detect the bacterial compounds. BNA stands for benzoyl D-L-arginine naphthalimide test. This test is used to determine the proteolytic activities of certain oral anaerobes that contribute to oral malodor. As you can see in this picture, this is Banner strip. Okay, this Banner strip works by combining the sample of saliva from the subject with the test strip, which composed of the Banner. This strip must combine with saliva, then only you can see the reaction. By the enzyme present in a certain form of bacteria found in the mouth will react with the Banner solvent and turn into a bluish color. It detects especially Treponema denticola, P. gingivalis, and T. photosynthesis that associated with the periodontal diseases. So by using the Banner test, we can detect not only halitosis but also periodontal risk assessment. So now I'm going to talk about investigation of allergy and autoimmune disorder, investigation of neuromuscular disorder, and miscellaneous. So the first test is skin prick test. Skin prick test is the most sensitive test for allergies. An allergist is trained to identify relevant allergens of the skin testing and to interpret skin test results. Skin prick test by an allergist is the most cost-effective than blood testing. So as you can see, if it shows positive test, that means there's a reaction here. If it shows negative, then there's no reaction. So the second test I'm going to talk about is the patch test. The patch test method is used to determine whether a specific substance causes allergies, inflammation on the patient's skin. An individual suspected of having allergies, contact dermatitis, or atopic dermatitis need patch testing. So how patch testing is done? Patch testing is done to see whether the particular substance is causing allergy to skin irritation, like contact dermatitis. Patch testing does not need needles. Instead, allergens are applied to the patch, which are placed on the skin during the patch test. Like your skin may be exposed to 20 to 30 extraction of the substance that can cause contact dermatitis. This can include latex, medication, fragrance, preservative, hair dye, metal, and resin. So you wear the patch on your arm or back for 48 hours. During this time, you should avoid bathing, like take bath and do some heavy activities that can cause you sweating. You should avoid that. So this patch is removed when you return to the doctor's office. And then if it irritates your skin, if this patch irritates your skin, it means you have allergic to the certain substance, the place where the allergic is caused. Now I'm going to explain about classification of vestibular disease. Vesicle and bullous means a clear fluid lesion just below the epithelium which rupture to form an ulcer. If this is smaller than 5 mm, then it's vesicle, as you can see in this picture. And if it's larger than 5 mm, then it is bulla, as you can see on the picture also. Intraepithelium vesicle means the lesion is formed within the epithelium. Acantholytic vesicle means this is because of the breakdown of the specialized attachment called the diadesmosome. Non-acantholytic vesicles is usually in the viral infections because of the breadth or the rupture of the group of the cell. What is subepithelium vesicle? It's a lesion formed between the epithelium and the lamina propria, and these are the examples for vestibular bulla. These are the example of the vestibular bulla. This you can read the clinical features, the histology features, the main target for the antibodies, and the immunofluorescence. This is your future for your reference. So what is Hasbro-Hansen sign? Hasbro-Hansen sign is when an intact bulla is pressed with a finger, one can see the fluids separating the adjacent epidermal areas, and the bulla enlarges on the periphery. What is Nikolsky sign? A bulla can be induced on a normal appearing skin if the firm lateral pressure can be exerted. If one pulls the ruptured top of the vesicle, the epidermis on the apparently healthy skin is separated. If in the result, if it's a positive sign, the positive sign in epithelial bullosa and also in Rett's disease. Now I'm going to talk about Malthox test. Okay, Malthox test is also known as PPD. PPD means purified protein derivative, or also known as TST, tubulin skin test. In simple term, it is known as a bubble test. So Malthox test is the standard method to determine whether a person is infected with Mycobacterium tuberculosis. The local skin reaction to the tubulin purified protein derivative injected into the skin is used to assess the individual sensitivity to the tubulin protein. Okay, Malthox test is given to which ages and who. Children ages 3 months to 6 years living at the high risk environment. Infant and child under 6 years of age with a history of residence of prolonged stay, which is more than 3 months, in a country of a high endemic. There's a history of TB in a household contact in the last 5 years. If the person, if the person had contact with any TB person in the house, like family members or anyone. Those who have had close contact with the person is known with TB. Now I'm going to talk about diagnostic nerve blocking. A diagnostic nerve block involves a numbing specific nerve or group of nerve that may be involved in a carrying patient's pain. A local anesthetic is injected in a very small amount into a targeted nerve, and the patient then they could not feel the pain. So if a particular pain-carrying nerve or group of nerve are numbed and the patients note significant improvement in pain symptoms, that means right after the injection, if you pinch or even you cut on the place, they could not feel the pain. So it's like an improvement. The location of the pain generates is likely confirmed. If a patient note no changes or limited changes in pain symptoms following a diagnostic nerve block, the treating physician may conclude that the patient's pain is originated from a different area. So now, how do you do the glucose blood test? Like, how do you measure the glucose blood test? Okay, the level of glucose in the blood can be measured by applying a drop of blood to a chemical strip. So you first have to prick the skin and take the drop of blood, as you can see in this picture. Okay, like apply the drop of blood into the chemical treated disposable test strip. You have to get contact to the test strip, which is then inserted into the electronic blood glucose meter. The electronic glucose meter will read the test will read your blood. So the reaction between the test strip and the blood is detected by the meter and display the unit. These are the units. You can use either this unit or also this unit. It is used as a screening tool for diabetes mellitus. And this is the table to see if the person is hyperglycemia or they are early hyperglycemia, or are they even normal, or they are early diabetes, or they are even a diabetic patient. So this blood glucose chart is a very important chart reference. Thank you.